Welcome everyone to Wednesday webinar. The topic today is hospital experiences with implementing rooming in, and we'll have Susan Spencer from Baptist Memorial Hospital Golden Triangle speak, as well as Joan Rooney from Ochsner West Bank and Cheryl Russell from North Mississippi Medical Center Tupelo. Just a reminder to remember to mute your line by pressing *6. You can unmute by pressing #6. And just remember not to press hold, otherwise your hold music will we'll all hear it. Before we start, I'm just going to go over a couple of CHAMPS announcements. The first one is that Dr. Meerwood and Kristen Crane from CHAMPS are visiting hospitals in Mississippi this week, so they apologize they won't be on the webinar today. Our next order of business is congratulations for Cassie Parks and her team at Christus Santa Rosa Hospital in New Braunfels, Texas. They are the first hospital in the CHAMPS South project to become designated. And Cassie's actually going to be one of the presenters for next month's webinar on staff education. And that will be on November 9th. And then our last webinar for the fall will be on December 14th, which will be about audit tools. Just a little update on some upcoming 4-hour clinical skills trainings. They're open to all of our CHAMPS hospitals, and the next one will be November 16th at Merit Health Wesley, and you can check out more details on our website. Along the same lines, in November we have 2 conferences coming up for CHAMPS. The first one is the Systems Conference on Monday, and that one is about a systems approach to baby-friendly, and that's invitation only. So if you received an invitation, you can RSVP to Lauren from Blue Cross Blue Shield, Mississippi. The CHAMPS Conference on Thursday is open to all of our CHAMPS hospitals and Tennessee hospitals, or Mississippi hospitals and Tennessee hospitals in CHAMPS. Sorry, and each hospital can bring up to 4 people to the conference, so please make sure you're registering for that, and it's very exciting. We're looking forward to it. I think that's all of our announcements right now, so I'm just going to pass it to Susan, and she can start. Okay, you should have it, Susan.
I have it. Thank you. Good morning. Okay, so Baptist Memorial Hospital Golden Triangle, we are a faith-based, not-for-profit. We deliver a little over 900 babies per year. When I came here almost 4 years ago, we had a mix of very eager, forward-thinking nurses and a few nurses that had the attitude of that's the way we've always done it. So I think that's pretty typical. I was an Air Force wife, moved around the U.S. I don't find that it's a lot different no matter what state or what hospital you're in. That tends to be what you find. The nursery nurse training that I found here at Baptist Golden Triangle, over the years, in addition or beyond nursing school, the nursery nurses had received most of their training from the pediatricians that they worked.
No time with nursery.
The pediatricians had each shown them how they preferred things be done. And as time went on, there was very little evidence-based nursing literature that they were utilizing for their practice. They went to nursing school and then followed whatever the pediatricians said that should be done. Hypoglycemia, hypothermia, hyperbilirubinemia, those protocols had not been updated. There was really no official rooming in policy or protocol to follow. We did fortunately have some rooming in because I think just over time the parents expected that they would keep their babies as much as they wanted, but there was a lot of thought that we were doing families a favor if we took the babies to the nursery during the night. So there was many offers to let them get some rest and take the babies to the nursery, both for formula feeding babies and breastfeeding babies. There was lots of encouragement to supplement, both from the nurses and the pediatricians. And almost never I'm sorry. Okay. I closed my office door because there were some visitors walking past, and I think they thought I was talking to them. So then when we did start to encourage rooming in, before we even started the baby-friendly journey, many babies were still returned to the nursery throughout the day and at night. Breastfed babies were routinely supplemented, and this was thought to help moms allow them to rest during the night, which, as we all know, is not very helpful. So just getting started with Baby Friendly and really sort of putting rooming into a new level did create some interest. I think when we started to take nurses to first the conference that was held in Tupelo, and then I think the next one we took was one that was held in Jackson. But the more nurses I took to conferences and the more they were able to get outside the local pattern, they were able to talk with other nurses, find out that it could work, and other people were starting to do it. I think just the excitement built by going to conferences. I took even some more nurses down to the conference that was on the Gulf Coast, which was kind of a stretch for us because it's a distance, but it just built even more and more. And the excitement that they brought back with them then, of course, rubbed off on the nurses who had not yet gotten to go to a conference. Everyone did not get to go, but the ones that I did, I really think that was money well spent. So as we went forward, I think CHAMPS was a big influence because of doing it methodically and collecting the data. I was able to show them the data. At first, we didn't have a way to collect the data on rooming in, except for just in our minds we were doing better. And then once we worked with our EPIC people at corporate, they were able to build a way in our medical record so that we could document when the baby was rooming in and when the baby was taken out and how long it was out and how, when it came back to the parents. So for procedures that needed to take place in the nursery, circumcision, whatever, that we could then document. So as you can see, just a little clip on the side here just for emphasis. Gathering the data for all the initiatives, I started a what I call my CHAMPS data, and even before CHAMPS sends it to me, I have the data for the month, and it looks very much like what I get from CHAMPS at the end of the quarter. So I can share it with them every month when I finish collecting the data, and that really inspires them. We keep it posted where the nurses can all see it. We also meet with them on our baby-friendly meetings. We meet with the community. We meet with other groups. And the nurses themselves are involved, some of them in these meetings, and they get to not only share among themselves here on the unit, but they can share with outside groups and show a lot of pride in this. So this is how it looked. Of course, we were not able to collect the data, so it looks like we were 0 in November when we really know we were doing some rooming in. But it was sort of up and down, but we are in the around 98th percentile now. I have the same, we're holding around 98% for September, and October probably won't look that much different. I'm really pleased with it. The one thing that we could do, and we don't keep the baby any longer than an hour, but the one thing that we're really going to hone in on now is doing the hearing screens in the room. I've not enforced that yet. Some of the nurses at night do it, but there's a lot of things they do at night, so I haven't pushed that one to the limit yet. The next steps that we have coming up, of course, are hardwiring. Every once in a while, when I do when I go out and do the audits for the baby-friendly dissemination phase, I find that somebody offered to take a baby to the nursery for the mom to rest, and I just cringe. So it's not yet completely hardwired. I permit, or we permit, and we understand that if the mom is educated in the importance of rooming in and she still requests that her baby go to the nursery, that's one thing. But when the mom tells me that the nurse offered to take the baby to the nursery, that's a whole nother story. I don't want it to look like we're suggesting that it's a good idea. And again, I don't want it to look like we're forcing them to keep their babies when they feel like that's the only thing that's going to make them rest better, and they're just convinced they need the baby to go to the nursery. I don't want people to feel like they're being forced into something they don't want to do. But I don't want us to be the one to suggest that they need to get some rest and we need to take their baby. We have one physician who has just come up recently with strong opposition to baby-friendly. I honestly don't know what happened to him because he was not this strongly opposed in the beginning. I think it'll die down, and we'll see. Pacifiers still are an issue. That doesn't really have to do with rooming in, but pacifiers are not hardwired. Supplementation methods need to be hardwired. What we say, I think everyone probably experiences the same thing. It matters how the words come out of your mouth. We're saying the same thing, but it matters a whole lot how we say it. And the challenges of breastfeeding. One of the things that I think I'm most proud of for the last couple of months, September, among the Caucasian women who are breastfeeding, we had 78% of Caucasian women initiate breastfeeding, and we had 75% exclusively breastfeeding. That's incredible to me because it's difficult to get them to exclusively breastfeed. And this is a product of following the pattern, saying the right things, rooming in. There's no other way that you could stop that much supplementation that was going on when we first started this and have 75% of the people exclusively breastfeeding. Now, of course, I'll really do backflips when we have more African American women who are breastfeeding, and that really is a cultural change that we would like to see happen. And working at that, it is getting better, but those other numbers are just incredible. So I guess now you can, I'll either take questions or save them till the end, and however you want this to go.
We can have questions at the end, but does anyone have any questions right now for Susan? Okay, we'll go to Joan Rooney next at Ochsner West Bank, and I just passed you the presenter, and go ahead and take it away.
Thank you. So with me here today is Leslie Wingirter. Leslie is actually our clinical coordinator on Mother Baby on Days. Beth Zabo, I'll put her on there too. She's my night charge, and this is their step. they own this step, rooming in, so it's very, so they had a lot into getting us where we are today. So just an overview, we are part of the Ochsner Health System, which is a very large health system in Southeast Louisiana. We are a community hospital. We have both employed physicians and community physicians. We do about 1,200 deliveries a year. We're currently in D3, and our plan is to move into D4 by the end of this month. I have the paperwork just about ready. I think one of the things that has kind of helped us is we've been doing mother-baby model of care since 1995. We did have a nursery, and similar to what the previous speaker said is that we always kind of did rooming in a lot during the day and evening, but it was at nighttime where our challenges were. So when we were tackling this step, we kind of had to like prioritize certain things, what's going well and where do we need to focus. And data collection was one for us. We have Epic, and we had no idea where we were, and we weren't doing manual audits before. So our system, which is the beauty of a system, because all of the rest of the hospitals in Ochsner or on the same baby-friendly track. And Ochsner Baton Rouge is the first hospital in the state of Louisiana to be baby-friendly. So they were designated about 2 years ago, and we learned a lot from them. So the rest of the hospitals in the system, birthing centers, we kind of all gathered together and kind of formed a system team, so to speak. But Epic was one, and so that was a big task force that actually worked with Emily Taylor to actually get that built in Epic so we can at least know where we were. As far as nurse assessments, for the most part, we were pretty consistent in doing those in the rooms. The night shift was the area we were having the most problems with, and I think some of our assessments, like the pulse ox study, was not really hardwired, them adding that to their assessment in the room. We do phototherapy at the bedside. That's never really been an issue, or if the mom's on medication, the baby's on medications with maybe just a septic workup until the cultures come back, so we do that at the bedside. We give the first dose of antibiotic in the nursery so we can observe that first antibiotic, but after that. So lab performing the routine PKU and Billy's in the mom's room. I'll talk a little bit about that in a minute. Our daily weights and baths, physician exams, the initial and daily exams, and then our newborn hearing screen. So that's kind of what we kind of were looking at. So like I said, we made changes to Epic, and it was really good because we have the location of mom and baby, and then on the right-hand side, not only where they were, I didn't put it in the next screen, but it also has a reason here. So why are they being separated? So we needed to know why they were separated at the time of separation and when they were going to be reunified. And the reason for that is so we could get our audits built, our reports built to know how we're doing and what's inclusion, what's exclusion. So with the nursing assessments, we just kind of, based on some of our audits, we just had to kind of tell the staff, look, if you're going in there to do your assessments, don't, you just bring your pulse ox monitor in there with you, don't forget to include this. And really it took the one-on-one conversations with the charge nurses to say, what's your barrier, what's your issue? And we just had to say, this is the way it's going to be done, and you need to do that in the room. So that was kind of an easier one. The lab was kind of nice. I'm going to let Leslie tell her story on the lab because we have lab as part of our baby-friendly team. So they knew a little bit about, what baby-friendly was all about.
So at first, lab was a little bit hesitant about going in the rooms because some of the staff were not comfortable with sticking babies, and especially sticking the babies in front of the parents. But we've kind of coached and gone in the rooms with them, and it's turned around, and they actually kind of like it because then they get the interaction with the parents. And this picture that they have here, this is one of the girls that's actually in orientation. And so the lab tech is bringing her orientee at the mother's bedside, and they had already asked, was it okay? And now it's just routine. And what we did was we have batched our PKU and Billy draws to be done twice a day, and we coordinated with lab to find out what's the best time that they had the most staff and what's the best time. So they kind of do it at 10 in the morning and 10 in the evening. And we have a clipboard in the nursery where we put all the flips for them to do. And they'll go in the nursery, they'll get the flips, and then they make their way around to the rooms. And it's really worked. We've been doing this almost since the beginning of our baby-friendly journey, so it's been a little bit over 2 years now. And it's really become routine. It's worked out great. And it's nice that it's one less thing off the staff that we don't have to do as well.
Yeah, and so, too, from a two-patient identifier standpoint, I mean, the mother's at the bedside, so they're confirming, you know, that that's, you know, the right mom, the right baby, but also the whole thing with making sure you have the right baby, because if they're lined up in the nursery, I mean, it puts even more of a risk of making a mistake. So that's another way to look at it. The baths and weights was sort of like a little bit more of a challenge. We heard from the staff, what are your challenges? So one of the things is we had an old kind of clunky scale, and it was making a lot of noise, and it was kind of heavy. So we were at the time in the process of having to convert to new scales anyway. So we got one, they trialed it, and it actually works really well, so it's easy to move around. And so we also wanted to make it convenient, so we're teaching the parents at the same time. In this particular example, Brianna's one of our night nurses, and they discuss with the mom what's the best time for us to do this, and we tell them we're going to teach you at the same time. So goes over a lot of that. It's a good time. Now, an alternative is every once in a while there's a baby, we're concerned about the temperature, and the room might be a little cold. So we'll take the baby into the nursery with the parents and say, we have some little chairs in there and say, come on, we're going to do a little class with the baby under the warmer. And it gives them an opportunity to take the time to actually do the bath without us having to worry a little bit about the baby getting too cool on the scale, so in the room. So that's worked really well, but the night shift had to kind of own this because that's when most of them are being done.
Dr. Call, this is Mrs. White.
Physician exams. So that's been a challenge all along. It still is. So we actually had, you know, you have to have some physician champions. We tell them that their biggest issue was the initial exam, because what we heard from them is our rooms, even in the cribs, it's not a flatter enough surface for them to really like maneuver all the limbs and everything that they want to see. And our lighting is not the best in the rooms, especially early in the morning when all the lights are out and you can't even open a shade because it's still pretty dark. So we compromised right now with the doctors. We told them, you know, if you don't want to do the initial exam, we'll bring the baby to the NOAA. But, you know, we told the nurses you can't line up all the babies, one baby at a time, no more than one baby at a time in there. So it gets the baby in and out. And then after that, the doctors agreed, okay, after the initial exam, I'll do all the other subsequent exams in the room. So it's sort of like what we compromised with them. We got them a designated computer on wheels so that they can round, the ones who want to round with that. The other thing is you really need to have a meeting with your peds and kind of explain. We've had to have a lot of one-on-ones with them, try to explain what we were trying to accomplish. And I think when we did a few PDSAs with a couple of docs, you know, they're going to tell you the same thing. You know, it's the lighting, the room's cold, I don't want to wake the parent up. You know, they're going to give you every excuse, but you just have to go back and say, okay, well, then I'll just invite the parent into the NOAA. We call it our newborn observation area, into the NOAA while you do the exam. So I think you got to learn how to work with your docs and kind of figure out what their real issues are. So I think the compromise for us right now is working well until we can move to that next option. The other thing is they know the babies stay in labor and delivery at least 2 to 3 hours. So we've told them, hey, if, you know, when we notify you have a newborn, if you want to just come, you know, the baby's going to be by mom, so you can examine the baby under the warmer in the LDR or on the mom's chest. So, and a couple of them have done that as well. So give them a couple of options, I think, is another thing. So I'll let Leslie talk about the hearing screen.
I wanted to say one more thing about the physicians. The OBs and some of our general practitioners was on the unit one day when we were speaking about the lighting in the room, and one of the doctors commented to the pediatrician, well, that's the same light we have to work with in the patient room, so what makes you so special that you need a special light? So that was quite cause for conversation there. And after that, that's when we had more buy-in from the pediatricians actually in the room when they thought about that.
Yeah.
So going to our newborn hearing screenings in the room, excuse me, we did have a little bit of challenge with that, but the last couple months, I want to say, we've gotten a couple people who've called themselves our champions, and they're like, you know, we're going to do this. So we rolled it in the room, and some of the obstacles that they ran into was that, you know, the TV was on or somebody in the room was on the cell phone, and we were having troubles with the hearing screener taking too long and everything. We found out through the company that those interferences do cause delays in the screenings, and so now we're better educated. So when we go into the rooms, we do let them know, please, you know, silence your phones and turn the TV off, and, you know, this is important, but it's really been a good thing. We find that the tests are actually, we did a kind of a PDSA to see taking the baby into the nursery to do the screening versus taking the, how long did it take to do the screening in the nursery versus how long did it take to do the screening at the bedside, and we were very surprised to find out it was actually less time at the bedside that it took for the test to be done. So that was quite interesting. And then when we could bring that to the staff, you know, we actually had proof. And so, you know, we've had a lot more buy-in since that time. We've also trained some of our techs to assist with the process of the ALGO training. They've been through class and signed off with our audiologist, and so they are certified to go and do it, and so that's helped a lot too. With the burden is not always on the nurse, that we can share, you know, that responsibility, and we get a whole bunch more done faster.
And the other thing about that is they, I think the PCTs and the secretaries who we additionally trained, they, first of all, they wanted to be, they asked to be, because I think they felt like they would be more involved in the baby-friendly being, you know, us meeting our rooming in, because they felt like they were more involved. So it really gave them a lot of confidence and feel like, okay, this is our team, this is something to help us be successful. So, I mean, that was aha for us, and because, you know, one of them comes down the hall, what, y'all don't have any hearing screens for me to do today? You know, like she feels disappointed. So try to think of what your ancillary staff can do also to make you successful. I guess that's my last slide. I can't click any further, but I do have one thing that it does help to visit other hospitals that are either baby-friendly or close to being baby-friendly. You get to talk to staff. The webinars are really helpful, but when you can send staff to another hospital, we went to Lafayette, we went to Baton Rouge, and it really does make them really engaged, and then that becomes your person you can talk to say, okay, what did you do about this? Every hospital, all of y'all are going to have your own little unique situations, but the more you can get information to kind of see, well, what else can I try next kind of thing. And if you could send a physician or two to a conference, that has really helped as well. And that's all I have. Thank you.
Thanks, Joan. excuse me, does anyone have any questions now? We'll have questions at the end too, but does anyone have any questions for Joan right now? If not, we'll move on to Cheryl Russell. I'll give you the presenter privileges and you can get started.
Okay, this is Cheryl, and I do have with me Angela Henderson. She's the nurse manager of our mother-baby unit. Just a little bit about our hospital. We are a freestanding women's hospital. It was built a little over 30 years ago. We do about 2,200 deliveries a year, and since our hospital was built several years ago, the setup is not ideal for mother-baby care, but currently we have separate units. Labor and delivery has LDR rooms. There's a locked unit, the postpartum unit, and then the nursery, which we combined last September. When we started mother-baby care, they were both separate locked units. So it was not ideal for the mother-baby care model, but we have been able to make it work. We do, since we're a freestanding hospital, we do women's surgery, labor and delivery, high-risk labor and delivery, and, of course, we have a level 3 NICU. So in our surgical area, we did not have a separate recovery room for C-sections. Our C-sections go through the regular surgery unit. They do have designated section rooms, but the recovery is with all the other patients, so that has been a barrier. We'll talk about that a little bit more later. We have had rooming in available for years, and it was encouraged, especially for our breastfeeders, but the baby always came back to the nursery for procedures, not necessarily for vital signs or assessments, but for procedures. And then also, we began skin to skin. We actually got approval in November of 2011, and this was really driven by our lactation consultants. We have 2 lactation consultants that have been here for years. Initially were nurses and went back and got their IBCLC, and they really have driven a lot of our practice changes. So in 2012, we implemented what we call the golden hour, which was skin to skin after delivery. It has really grown to be about 2 hours most of the time, sometimes a little bit more. But because of the way our building is set up, we did not, in some, I guess, restrictions from our anesthesiologist, we do not do skin to skin in the OR. We do skin to skin in the recovery room. And then last September, we actually began mother-baby care. So prior to mother-baby care, like I said, we had separate postpartum and nursery areas. They're locked up separately. And then we also had separate staff. Some of the staff were cross-trained, but when they came, they really they were able to help, but they did not function independently usually. Except we do have our own women's and children's resource pool, and those staff were trained to work both postpartum and nursery, as well as intermediate care in the NICU, and some worked labor and delivery. So in preparation, we did start cross-training our staff as staffing would allow. We set a target date several months in advance for when we wanted to implement mother-baby, but when we got to the implementation time, several of our staff were not trained, and the ones that were still weren't totally comfortable in both roles. So the way we started with one nursery nurse working with one postpartum nurse, and they would take 2 couplets initially and work together and learn from each other. Eventually they started taking 3, and another thing that we found was that the resource pool nurses were a great asset because they knew both roles, the care of the postpartum patient as well as the care of the baby, and they were able to step in quickly and do their couplets independently, or they could work with a nursery nurse or with a postpartum nurse if we need them to. They also were a very positive influence. Some of the unit-based staff were also very positive and supportive. Others, as you would expect, were not so supportive. And it probably took 2 to 3, maybe 4 months for implementation. So during that time, we had to have extra nursing staff available. When we ran into challenges because the staff were not available, what we would sometimes have to do is back up, and we would let somebody that was comfortable with the babies work with somebody that was comfortable with the mothers, but they would have the same couplets assigned, but they would just care for either the baby or the mother. But most of the time, they were working together, teaching each other the roles that they were unfamiliar with. Due to our facility layout, too, we felt like it was important that we continue to have an admission nurse. This nurse, we have one every shift. Some shifts we have two. They don't attend the deliveries, but they do go to labor and delivery and take care of the baby. They go back and do their initial assessment at 30 minutes unless labor and delivery calls us to come earlier if there's anything that we need to assess earlier. So during the golden hour, it's every 30 minutes they're assessing the baby. Both the labor and delivery nurses and the nursery nurses are all trained to assist with breastfeeding as needed. And then following the golden hour, they had to do assessment, weigh the baby. They may do the bath and the admission meds in the LDR room before they go to the floor, or it may be done after they transfer to the mother-baby unit. One thing that I did fail to mention, I know in 2010, we started teaching our own 2-day breastfeeding management classes here. The 2 lactation consultants that I mentioned, Karen and Sabrina, that were so involved in helping us as we made all these changes, went to a class to learn how to do teach the 18-hour course. And in 2010, we began teaching that course to all of our staff. So we've had a lot of education for our nursing staff for the last 6 years. They've been getting a lot of breastfeeding education. As I mentioned earlier, currently we're not doing skin-to-skin in OR. Our babies that are delivered by cesarean come to the nursery until the mother arrives in the recovery room. If the mother's awake, then she does see the baby briefly in the OR, and then the baby comes to the nursery we have a neonatal team that attends all the C-sections, a nurse and a respiratory therapist. So they bring the baby to the nursery, and the admission nurse would watch the baby and do the vital signs until the mother was in recovery, and then we take the baby to recovery and stay with the mother and the baby throughout the recovery period, and the baby would go to the floor with the mother on the mother's chest and would be able to continue skin-to-skin there. As far as our procedures, we had a little resistance early on with doing the hearing screens and the lab work in the rooms, but it only took, I would say, a couple of months, 2 or 3 months, and everybody was pretty much comfortable doing everything. The hearing screens are routinely done in the room. The lab comes to the room to do the lab work. The congenital heart disease screening the nurse does in the room, and medications or immunizations as needed. We did have resistance from the pediatricians, especially when, if they had 20-something or 30 babies to check in the morning. There was a lot of resistance from them because they felt like this was more time-consuming. We did not meet them halfway, really, with that. We did offer to send a nursing assistant or a nurse or somebody with them to undress the baby. As they were checking one baby, they would go to the next room and undress the baby and have it ready. Some of them liked that, some didn't act like it helped a lot, but we did stand our ground about they wanted the babies all brought to the nursery when census was high. And we told them, you know, that we weren't going to do that. They had agreed to this originally. And after a little bit of time, I guess they've come around or they've accepted it. We do still try to help them and have, you know, things ready for them. But we don't bring the babies back to the nursery for them to check. They occasionally get to check one that has come back for a circumcision, but or that, you know, the mother's still in recovery and still in surgery and the baby's in the nursery, but the majority are always in the mother's room. Our challenges, I would say, have been coordination of care. You know, I assume every hospital is like ours. There's a bunch of people in and out of the mother's room every day between the pediatrician, OB, the nursing staff, the person from medical records doing the birth certificate, the newborn photographer. There's just a lot in and out of the mother's room. The lactation consultant if they need to see them. So we have had challenges with that, trying to make sure that we did not, trying to make sure that we bundled our care and did as much as we could at one time, especially on night shift. And then we have had some challenges with our patient satisfaction. Some of our patients absolutely love the fact that the baby is in the room with them all of the time. But then we also have another population of patients that, you know, really want to sleep, get a good night's sleep while they're in the hospital because they know they assume they won't be getting it when they are at home. We do, if they are exhausted and they request, we educate them about the benefits of keeping the baby in the room. And then if they still want us to take the baby out, we do. We don't have a whole lot that do that. I don't know if it's because we make them feel guilty with the education, but we have had some challenges with our patient satisfaction. So if either of the other hospitals that are presenting or anybody that's doing this baby rooming in or mother-baby care have any suggestions for that, I'd love to hear them. Our other challenges have been our documentation. We don't use Epic. We have a system called SEM, and getting the screens, the documentation, flow sheets, how they need to be able to capture the data has been kind of challenging. And then we have had some staff turnover too, and the majority of it I don't think has been related to our change in our care model, but we have had some staff turnover, so I think that just trying to keep everybody on the same page about what's required as far as our rooming in. A couple other challenges I didn't put on the slide that I thought about were low temps. We still have staff members that think if a baby gets cold, it's better to go back to the nursery and be in an incubator, and we continue to struggle with that. And sometimes if they call the doctor, then they want them to go back to the nursery as well. When actually, if the baby was skin to skin, it would probably be warmer than in the incubator. And occasionally with hypoglycemia as well. Some things that we might do differently, and these were my thoughts, Angela may have additional ones, probably more scripting on the front end so that we can be consistent in what we communicate to our patients. More education and preparation for staff. You can never have too much education, and we had done quite a bit, but I think if they understood more about baby-friendly and the guidelines that we're trying to meet, then I think they might have understood a little better what we were trying to do. And also, we had made probably a couple of months before we implemented mother-baby care, we had made some significant changes in our glucose protocol. And the changes were good, but the nursery staff, most of them were feeling pretty good with them, but then trying to educate the mother-baby, the postpartum staff about those. And so I'd probably recommend not, if you've got any other major changes, to have a longer period of time before you implement rooming in or mother-baby care. I think on the last slide I just put some of the next steps that we're considering. We do plan to make some changes in the recovery room so that the father will be able to stay with the mother and the baby during the golden hour after a C-section. We also plan to do some renovation and move the nursery closer to the mother-baby unit. The downside to that will be that it will be further from the labor and delivery rooms. We plan to continue to focus on coordination of care and improving our patient satisfaction scores. And then a consideration for maybe the admission nurse being more involved in attending the deliveries. I think that's all that I have, and so I'll turn it back over to Kristen.
Okay, thanks, Cheryl. Does anyone have any questions for any of the presenters? I also just wanted to remind everyone that our the slides for the webinar are actually already on our website, and then the recording of this webinar will be uploaded to our website by either this afternoon or tomorrow. And then also the upcoming webinars, just wanted to give you guys a quick reminder that our next one is November 9th, which will be about staff education. And then on December 14th, we'll have the webinar about audit tools, and that will be the end of our fall/winter webinar season, and then we'll start again, I think, in the beginning of next year.
I have one quick question. Hello?
Hi, go ahead.
Can you tell me what hospital is Susan Spencer? Where is she?
Hi, this is Susan. I'm at Baptist Memorial Hospital, Golden Triangle in Columbus, Mississippi.
Okay. Thank you.
Sure. And who was asking?
This is Shannon Grosh from Toro Infirmary. I'm one of the lactation consultants here.
Oh, awesome. Meet you over the phone.
Nice to meet you, too. Thank you so much.
Hi, I have a question. This is Philippa Howard from New Mexico, and I had a question about, Cheryl said that she had an IBCLC trained to teach the 18-hour course. Could you give me some more details about where that was, who it was through?
I can. I may have to get your information and email that to you. It's been several years since they went, but and somebody else may be able to answer that's more knowledgeable. But they went to a week-long conference where they were taught to teach the 18-hour course. And
I'm sorry, what was the name of the conference?
I'm sorry?
What was the name of the conference?
I'll have to ask them. If you'll give me, if you want to email me.
Yeah, sure.
My email is crussell@nmhs.net.
Thank you.
And I had a couple of questions too for Susan or the other presenter about if they saw any changes in their patient satisfaction and what they did to improve it, and also about at what time of the day they are weighing their babies.
This is Susan. We weigh our babies fairly early in the evenings, and we do it in the patient rooms. This way, typically they used to be weighed at midnight. And when we started with more hardwiring of the rooming in, we decided that the parents would be a little more satisfied if we were not doing this in the middle of the night or near midnight. So we do that on the rounds when they're, like let's say 9, 10 p.m. The babies can also be bathed at that time if they need a bath, and we do it in the room. The babies just go back skin to skin with mom if they need to be warmed. We don't take a warmer into the room, and it's just absolutely just a sponge off. It's not like lots of running water, like the initial bath that they receive, but we do that in the room as well, and then put them skin to skin with mom, warm up. The other thing, what was the other question you had? I'm sorry.
I'm sorry, patient satisfaction was the other question.
Patient satisfaction, yes. No, we've not experienced any change in patient satisfaction that's related to rooming in. We have experienced a change in patient satisfaction recently, and I'll tell you what it has to do with. It's the scores for talking to patients about their medications and side effects. And so we've got to relook at that, revisit that. That's what has dropped our scores down. It has nothing at all to do with rooming in, so that's kind of an interesting sidebar. But typically our patient satisfaction scores, since I've been here, have been in the 90s as far as overall percentile. And all of our nursing scores have stayed in the 90th percentiles except for those specific questions about did the nurse explain medications to you and did she talk to you about the side effects and all, those ones toward the end of the surveys, and we just got blasted on those. So we have signs on all of their computer station, rolling stations, the WOWs that we call them, a sticky note attached to every one to make sure that you talk about medications and side effects, because that has really knocked us down to scores that we've never seen before.
This is Joan. This is Joan. I'd like to respond to. So again, we saw a little drop, but not really much, because our big areas were responsiveness, and we were focusing on responsiveness and communication with nurses. So those, because we're rounding, we're doing hourly rounding, so we coordinate our care and round on both the mom and the patient, the baby, and they're using their call light less because we're trying to address everything in the room at the same time. For us, the bath, the night shift worked that out. We said when you go in to meet your patient for the first time, let them know you need to do the bath and the weight, or mainly the weight, and find out when they want to do it. Most of them are done earlier in the evening, and if there is one that's a little bit later because the baby hasn't slept, we just say when the baby's awake, no matter what time it is, call us and we'll come in and do the weight at that time. So it's really kind of telling them to work with the parent and of what's the best time for them.
Thank you.
Yes, and I'll echo that. This is Susan. That works really well for us, and the algo, the ones who do take the algo out to the room, are using that also with bath and weight and breastfeeding, and then do the algo right after the feeding. They're learning how to really coordinate the care and do these at optimum time.
Does anyone else have any other questions? Remember, you can unmute by hitting #6.
This is Shannon Grosh again from Toro Infirmary. I have a question for Susan and Joan, and if anybody wants to chime in, related to the 5 hours of didactic training that the nurses need. How are they going about doing that training?
Hey, Shannon, if you just want to call us, call either Sherry or Tracy. We'd be happy to tell you what we did. But we actually used some of the information when CHAMPS came and did a session here with the different topics. And we do an annual skills fair, a unit skills fair. And this year, our unit skills fair was going to be all about baby friendly because we had to get everybody trained. So we have a couple of dates. And we told them what all the stations were and about how long it would take them to go through the stations to learn the skill, because it might have been a demo, it might have been repeat back, it might have been watching a video and telling us something about it. So we can kind of share with you, I think I have your email, I think I can share with you the content of what we did.
Oh, that would be awesome. When is that skills fair? Did y'all already have it for this year?
We have our second one on the 28th, next Friday. So if you want to come and watch, I'll send you. It's going to be from 8 a.m. to 2 p.m. So yeah, be happy to have you come over.
Oh, thank you so much, Joan. That's wonderful.
You're welcome.
Okay.
And this is Susan. We did the CHAMPS class that, what's her name? Kathy Carruthers taught. And she came to our hospital. We had a few people from other hospitals, but mostly our nurses, and we were able to get almost everyone in. I'm a lactation consultant, IBCLC, and we have one other one in the hospital here. So we are going to hold classes for the ones that missed those classes. And the ones who got those classes, the 5th hour, I have checked almost everyone off with observing them in the patient room.
Okay. And is that the train the trainer that you're talking about?
That, no, it's not train the trainer.
Okay.
It's the 4 hours. They actually do a hands-on 4-hour training with capacitors, and then I will teach the same class that Kathy Carruthers taught, so she shares her slides with me. The 5th hour, so this is the 5 hours of hands-on training, because they have the squishy breath that they use in the classroom, and they return demo in the classroom. But then the 5th hour is really at the patient bedside, so we're checking them off at the bedside.
Okay, great. Thank you so much.
Are there any other last-minute questions? I have about 2 minutes. Oh, go ahead.
I just want to say one other thing about staff training. We have to have every year a hospital skills fair, and we decided we needed to let everybody know we're on our baby-friendly designation and what that meant. And not that you went into a whole lot of detail, but you'd be surprised. We did it last week, and we're going to do it again next week. More engaging into all the staff knowing what we're trying to accomplish here, and what, depending on where they work, what kind of situations they may have with either a mom who just had a baby or a mom who's pregnant or whatever. And it's really raised awareness of what we're trying to accomplish and what they've heard about skin to skin and what they've heard about rooming in, what they've heard about not buying formula. And so you can dispel a lot of myths out there. But it's also increased employees who are getting ready to have a baby, knowing what's going to happen and where they can go to pump and access to a lactation consultant. To me, that's been the big aha. It's like, oh, we didn't know we had a place we could go and pump our milk while we were at work. So if you ever have something like that, think about it. Doesn't have, you're not detailed, because some people don't even, why am I having to learn about baby friendly? But we've really kind of increased awareness of what baby friendly is all about. So.
Okay, thanks everyone. It's the end of the hour now. If anyone has any other questions, feel free to contact us and we can direct you to whoever you have a question with. Thank you so much to our presenters today, and we hope we'll see you at our next webinar. Thanks everyone.